Okay, so blood 2. Blood 1 was all about the erythrocytes. Now we're going to talk about the leukocytes and platelets today. So we'll talk about the classes, structural characteristics, and functions of leukocytes, although we did already talk about them a little bit in lab last week. We'll describe how those leukocytes are produced. We'll talk about leukocyte disorders and what goes wrong with each. We'll talk about the structure and function of platelets. We'll talk about hemostasis, which is the stopping of blood. And we'll talk about the factors that limit clot formation and prevent undesirable clotting. And then we'll talk about blood testing at the end. And then your lab for today is going to be on ABO blood typing. So just to review, what's the blood cell type that the arrow is pointing to? Erythrocyte. What's the general term for these larger cells? Well, all of them. Leukocytes. And so what's this one specifically? With the red granules? Eosinophil, yeah. What are these fragments that are throughout? Platelets. What's another word for platelets? Thrombocyte. What is that larger cell? What is it? Monocyte, yeah. Yep. And then this guy right here is a lymphocyte. You could tell it's a lymphocyte. It's not a basophil because a basophil, and why isn't my pen working? Hold on. I need to save it. Save. You can tell it's a lymphocyte because it's only slightly larger than the erythrocyte. If it was a basophil, it'd be closer in size to the eosinophil. That's kind of how you can tell the difference. Because they both will look like big blue, purplish circles, but you want to look at size as well. Okay, here's another one. What's number 1? Erythrocyte. Number 2, platelets. Number 3, neutrophil. It has 3 pieces of its lobe there, or 3 lobes of its nucleus. Number 4, eosinophil with the red granules. Number 5, that's not a basophil. Still a lymphocyte. It's not nearly as big as that eosinophil. And then number 6, monocyte. All right, so when we talk about blood, like for erythrocytes, it's 5 to 6 million red blood cells per microliter, depending on male or female, female being 5 million, males being 6 million. Just to give you a visual of what a microliter is, so here's obviously a big liter of fluid in the back, if I could get this to go back. So all the way to the left is a liter cylinder. Then this little tiny test tube there is 1 milliliter. And then this tiniest drop, that is a microliter. And so we have 5 to 6 million red blood cells, along with white blood cells, along with platelets in that little microliter of blood, which is pretty amazing. So review from your last lab. Is that we have granulocytes, which are going to have granules in their cytoplasm. That includes neutrophils, eosinophils, basophils. And then our A granulocytes are going to be our lymphocytes and our monocytes. We'll talk about the abundance a little bit later. One thing to remember is that your total white blood cell count should be about 5,000 to 11,000 microliters. I always forget that little thing needs to go on the other side. So your book gives a more accurate number of 4,800 to 10,800, but I'm okay with you rounding up to 5,000 to 11,000. So that should already be in your notes. And it's per microliter of blood. And then white blood cells are going to function to protect you from bacteria, viruses, parasites, toxins, tumor cells, even though they shouldn't. Also transplanted organs as well. So white blood cells are going to protect you from anything that they deem as foreign or doesn't belong. So anything foreign with foreign antigens. And antigens we'll talk a little bit more about later, but antigens are proteins that we find on the surface of our cells. So antigens are essentially identifiers for cells on the cell surface. Antigens are what are going to tell us if you're A type, B type, AB, and we'll talk more about that later. Okay, any questions so far? So a little bit about how leukocytes behave. You should already know from the integumentary system and the inflammatory response. So white blood cells have the ability to move to areas of damage, so they can leave the bloodstream and go to a site of injury. And they do so by positive chemotaxis. So whenever we have an injury, there's inflammatory chemicals that get sent out that act as a signal so that white blood cells know where the injury is and can go in that direction. Okay? Positive chemotaxis, positive means towards. Chemo referring to chemicals. And taxis is movement. So it's the movement of white blood cells toward a chemical. Oh, why did I say taxis? I must have been thinking about the time of year and W-2s and all that. It is. So positive is towards, chemo is chemicals, and taxis is movement. So again, it's a movement towards a chemical signal. And then I'm going to erase that movement really quick. And taxis means movement. Another way that they know kind of where to stop and where to get off to where the site of injury is that inside the blood vessel, there are some things called cell adhesion molecules. And those cell adhesion molecules are sometimes abbreviated as CAMs. And so there are cell adhesion molecules that are displayed by epithelial cells inside the blood vessel to tell the white blood cells where to get off. It's kind of sticky. So these cell adhesion molecules are sticky, so it kind of slows down those white blood cells so they know, okay, this is where I need to get off. This is where the site of injury is. It's kind of like the bumps that are right in front of a building that'll tell a blind person that they are about to walk into a street. It's very similar. They're going to slow you down, and they're going to stop you in your place and tell you, okay, this is where you need to get off. Okay, those are cell adhesion molecules. And then we have the way that they move. So once they get out, or actually this is the way they get out of those blood vessels. So one of the other things that inflammatory chemicals do is it makes those blood vessels here leaky. So they become very permeable. Spaces get created in between so that they can squeeze out of that blood vessel into that site of injury. And so the way that they squeeze through the spaces here, okay, that's called diapedesis. So diapedesis is the squeezing of white blood cells in between the spaces of blood vessels to get out of the blood into a site of injury. So imagine this is our blood vessel. There's now spaces in between because the inflammatory chemicals like histamine made them leaky. And then now these blood cells can squeeze out. Ooh. So that's diapedesis, them squeezing out of the blood vessels to wherever the injury is. Once they get into the tissue space, they move by something called amoeboid movement. And amoeboid movement, so hard to say with the boid, amoeboid movement. And it's called that amoeboid movement because they literally move like an amoeboid. So amoeboid is a single cellular organism. And the way that it moves, which is pretty cool. So do you guys remember the name of all the proteins and filaments that give the cell its shape and structure, what that's called? Starts with a C. Cytoskeleton. So how amoebas move is amoebas will break down their cytoskeleton in the back and then move those filaments to the front, making them inch kind of forward a little bit. Then they'll break down more of their cytoskeleton, move those proteins to the front, and that's how they can propel themselves forward. So they don't have legs or a tail like sperm do, so they basically break down the back of their cells and move it to the front. And then break down more of the back of their cells and move it to the front. And that way they inch their way forward. So that's how the white blood cells move. It's called amoeboid movement. Amoeboid movement. And so when you do have an injury and an inflammatory response where you have all of these white blood cells coming to the area, as well as the fluid or plasma within the blood comes to the area as well, you may form some pus in there. And pus is essentially just extracellular fluid plus some dead white blood cells and then any dead tissue cells as well that were injured during that time. I know the seats in here are not the best at all. If you like go across, they have like the long tables that are all nice. They need to do that in here. Okay, any questions about how leukocytes behave? Okay. No, I want us to watch this. Why does this always happen? What is the... I wonder if I can get the link. I've been able to do this before. I don't want that. See if it'll show me on here. Is it gonna show me? Why does this always happen? I'll have to show you later. I'll show you in lab. But it was going to show you kind of how those white blood cells move, and I've downloaded this before, so I'm not sure why it's not working, but we'll figure it out later. I'll show you in lab. But, and I'll send you guys a link on Discord so you guys can see the way those white blood cells move. So, leukocytes defend the body. We're going to talk about each one of these blood cell types. What's the first one that you see? That is a neutrophil. It is multi-lobe. There's 3 pieces of its nucleus. How many lobes could a neutrophil have? 3 to 5. What's the next cell type there? Eosinophil has the red granules and it's bilobed. What's the next one? Basophil. And like I said, underneath the microscope, the granules and the nucleus are so similarly colored. And there's so many granules that you can almost not even tell what the nucleus looks like. What's the next one? Lymphocyte has that round nucleus that takes up most of the cell space. And then our largest one all the way to the right, monocyte. Okay, so we're going to talk about their functions individually. One thing to remember is that white blood cells are the only true cells that we have in our blood. Okay, remember, red blood cells are lacking a nucleus, they're lacking mitochondria, they're lacking a lot of the other organelles, and they're really just to carry hemoglobin and oxygen. And then our platelets, they're just fragments of a larger cell. Does anybody remember what that larger cell was called? A megakaryocyte. We'll talk about it again in a few slides. Those are just fragments of a larger cell. So our white blood cells are our only true cells that have a nucleus, have all the proper organelles. So we'll talk about each one individually. So neutrophils, they migrate toward inflammatory chemicals, which is why you may have irritation during an inflammatory response. They are phagocytic, so they can engulf their targets, and they tend to target bacteria specifically. So whenever we have a bacterial infection, the number of neutrophils will increase, and then also the percentage of neutrophils will also increase. And there can be another video that I want to show you, so I kind of want to pull up the PowerPoint here just quickly so I can show you. All right, so those are neutrophils. Next are our eosinophils. They are attracted to areas of inflammation, and they are involved in the allergic response, but not as big of an extent as our basophils. They specifically work in our mucous membranes. And they protect against parasitic worm infections. And so if you were to eat bad shellfish and were to ingest a parasitic worm, it is eosinophils that help you fight that off. Now, parasitic worm is going to be way too large for an eosinophil to phagocytize, so they don't do phagocytosis. And I want to show you the video of what they actually do. So first I'm going to show you those neutrophils and how they move. So this is a neutrophil moving by amoeboid movement. So again, it breaks down its cytoskeleton in order to move forward, and then you're going to see it engulf that bacteria here in a second. And then swoop, now it's engulfed it. Now I can break it down and recycle the parts. Now, again, eosinophils, they fight off parasitic worms. Those are going to be much larger, so a single cell cannot engulf a parasitic worm. They use actually enzymes to degrade their target. Go back. So here's a parasitic worm, and then you can see eosinophils coming to attack it all at once. So they're going to release enzymes onto this parasitic worm, and it's wiggling now, but it'll stop wiggling here in a second. But they're just going to crowd all over this parasitic worm, release enzymes to break down its parts until it dies, and then they can recycle it. So those are how eosinophils work. Questions about that? Okay. And I'm sorry to anybody watching the recording who didn't see those videos. I will put a link underneath the recording so you guys can see those videos. So next is a basophil. Again, also bilobed. It's going to have now purplish granules. It's also attracted to areas of injury and inflammation, but its job in the inflammatory response is to release histamine. And histamine is what makes your capillaries leaky and more permeable. So the histamine is going to cause vasodilation. It's going to make the vessels larger and more leaky. Causes vasodilation during an allergic reaction. And RXN is a shorthand for reaction. There's a similar cell, if you've studied the immune system, that are called mast cells. Basophils are very similar to mast cells, but the mast cells are what you find in the tissue versus a basophil that you find in the bloodstream. So this is kind of how they create the watery eyes and a runny nose and such when you have an allergic reaction. So remember when we talked about the 3 fluid compartments, protein shouldn't be able to travel across from the plasma to the interstitial space. Yeah, David.
What is vasodilation?
So vasodilation just means that it dilates or makes the vessels larger, and they're going to be more leaky or more permeable to things going in and out. But again, when we talked about the different fluid compartments, that protein is not allowed to go from the plasma to that interstitial space. We should have little to no protein in this space. But when histamine is released during an allergic reaction, it makes the spaces in between these 2 fluid compartments larger. So again, if this is the plasma, and this is the interstitial space, it's going to create spaces in between the cells that are lining the vessels, specifically the capillaries, and so fluid is allowed to go in and out. Another thing that's allowed to go in and out are proteins. Now there's bigger spaces, so proteins can now leak into that interstitial space. And what's going to happen is water is really attracted to protein as well. So the more protein that gets into that space where it's not supposed to be, water is going to follow and end up in other spaces where it shouldn't. And that's when you have the watery nose, the watery eyes, and things like that because of the water escaping, because of the proteins allowed to leak in that in-between space. Okay. Does that make sense? Any questions about that? Okay. Next is the lymphocyte. Its nucleus is round and takes up most of the cellular space. If you do see some cytoplasm, it's going to be a very thin sliver of cytoplasm. We have two main types of lymphocytes. We have T cells and we have B cells. Our T cells, they can either message other white blood cells to tell them about a foreign invader, or they can also help activate other T cells. And these ones are called helper T cells. And we'll talk more about them and how they work when we get to the immune system. And then other T cells can attack invaders directly, like viruses or tumor cells. Could be fungi, could be transplants. But these guys are called cytotoxic T cells. And then our B cells, they can make antibodies or our immunoglobulin proteins. And remember, the liver can also make those immunoglobulins as well. So know that they both have the ability to do that. Liver cells and B cells can make immunoglobulins. Although the ones that are made by the liver tend to kind of stay more in the liver. We have more of the antibodies made by B cells than we have the ones that are made by the liver. With lymphocytes, its percentage and number are going to increase in viral infections. But sometimes that means that other white blood cell types, their percentage will actually go down. And I believe that's in your notes. Questions about lymphocytes? Okay. And then I mentioned to you before that our B cells, we also have memory B cells, and those are the ones that stick around for years and years so that we can recognize a infection or a bacteria, virus, what have you, that we've been exposed to before. So in case we're ever exposed to it again, we have a faster response. And again, we'll talk more about that with the immune system. Monocytes, they are phagocytic. They are the largest of our white blood cells. They're going to have either a kidney or C-shaped nucleus. And these, yeah. Yeah, yeah. So percentage of lymphocytes increase during a viral infection, but sometimes that can mean that other white blood cells, their percentages will go down. Monocytes are unique in that they can leave the bloodstream and go to tissue areas for cleanup. And when they do go to an area, or when they leave the blood and go into tissue, they're called macrophages. So in the bloodstream, they're referred to as monocytes, but when they escape the bloodstream and go to tissue, they are called macrophages. So questions about those white blood cell types? Okay. So this is showing you, this is a monocyte here. Let me get a brighter color. So this is the monocyte here. These little balls over there are yeast. And so you can see these little strands here are pieces of the plasma membrane trying to engulf or phagocytize that yeast. Eventually, the plasma covers it more until it engulfs it completely and brings it inside to break it down. All right. So the next part of your lecture notes talks about the production and lifespan of leukocytes. So white blood cells, they can live for months to years, but the ones that are actively fighting infections, they usually only live for days at a time. Leukopoiesis is the term for white blood cell production specifically, or leukocyte production. You're going to hear me say both white blood cell and leukocyte, but remember on a practical, you need to say leukocyte. But for time's sake and saving time, white blood cell. So leukopoiesis is white blood cell production. What was the word that we talked about last week, which is the word for all blood cell production? What is it? Hematopoiesis is for all blood cells. And what about for just red blood cells? Erythropoiesis. So leukopoiesis is now just the production of white blood cells only. And then you can see that they start with a hematopoietic stem cell, just like we saw with the erythropoiesis. And then they differentiate, become more specific, down a couple of different blood cell lines. And then they eventually become all the white blood cells that we talked about before, after their development. You don't have to know the steps, but there are a few key steps that we'll talk about here in a little bit. So we talked, what was the hormone that increases red blood cell production? EPO. Okay? We have different chemicals or hormones that are going to control white blood cell production, and those are interleukins. They're usually numbered like IL-3, IL-5, numbers like that, but you just need to know them as a group. They're interleukins. And then also colony-stimulating factors. So these are going to direct white blood cell production. And these chemicals, they can travel in the blood. What do we call chemical messengers that can travel in the blood? Hormones. So they can act as hormones. And then what is it called when it's a chemical that's sent out by a cell and it attaches or targets a neighboring cell? Paracrine. So these chemicals can act as hormones and paracrines. So they can travel through the blood and target the red bone marrow specifically to increase white blood cell production. But then they can use these chemicals to communicate with each other to help with like the cloning process, to make more of themselves when it's time to fight an infection. So, and everybody good here? Okay. If white blood cell count is low, we can give interleukins. So we can prescribe interleukins to increase their production. Or if white blood cells are attacking our own body, or if we're producing way too much, like in the case of leukemia, then we can give interleukin blockers so that they're not binding and they're not causing the white blood cell production. So again, we begin with one stem cell called a hematopoietic stem cell. When it's a hematopoietic stem cell, it can become any one of the blood cell types, any white blood cell, erythrocyte, megakaryocyte. But once it becomes differentiated, so once it becomes here and here, then it has to stay on that cell line. And it's going to develop further until it becomes these specific white blood cells that we talk about in lab. Now, one part of their development is before they're mature, they become what are called blast cells. Okay, these should be in the bone marrow only. They are not developed enough. They should not be circulating. They haven't been trained. They don't know how to fight infection. They don't really know how to do any of their functions just yet. So if we do find these in the blood, it could mean that that person has leukemia, where they are producing too many white blood cells, too many immature white blood cells, and putting those into circulation. And because they don't know what to do, they don't know how to function as an immune cell, they start attacking the entire body. Okay, because they haven't gone through the proper training. They haven't gone through enough development to know what is foreign and what's not foreign. Band cells are a little bit further on in the development of these white blood cells. Band cells are like the step before maturity. So they know pretty much what to do. They know how to tell a self cell from a foreign cell. So they've been trained enough. So if we see these in the bloodstream, it could just mean that we needed extra white blood cells because we have an active infection. Okay, so it's okay to see band cells in the blood. Again, it can mean that you have an infection, but you should never see blast cells in the blood. Those are far too young, far too underdeveloped, and they should not be circulating. So questions about the difference between blast cells and band cells? Should only be in the bone marrow. Yeah. Blast cells should only be in the bone marrow because they have not developed enough to be trusted out in circulation. Any other questions? Okay. So some leukocyte disorders. Leukocytosis is very, very broad. All it means is an elevated white blood cell count. So leukocytosis doesn't tell you much. It could mean that you have an infection. It could mean you have leukemia, which are two very different things. One is way more severe than the other. So leukocytosis is just very broad to say that you have an elevated white blood cell count. Leukemia specifically is the cancer of white blood cells, where you have not only an overproduction of white blood cells, but an overproduction of immature and abnormal white blood cells. So this is when you see those blast cells in the blood. And because I get this question all the time, there are different types of leukemia. There's myeloid leukemia. There's also lymphocytic leukemia. Lymphocytic is this one. It's much more survivable. You don't need to know these numbers, but about 71 to 90% of the people with lymphocytic or acute lymphocytic, which means it's rapid onset, it progresses quickly, but 71 to 90% of these people will have a 5-year survival rate versus the ones over here. If you're over 20 and you get acute myeloid leukemia, it's only about a 28% of a 5-year survival. So a much lower survival rate, a much worse prognosis if you have myeloid leukemia versus lymphocytic leukemia. But that just means, that's just telling you which stem line they come from. Yeah?
So when you say 5-year survival rate, are you saying that they only survive for 5 years after they...
No, that's just kind of how they measure cancers, is what's the 1-year survival rate and then what's the 5-year survival rate. They don't really track after that. But people who have a 5-year survival rate, many of them are going to live even longer than that. Yeah. That's just kind of how they gauge the success of the treatment. If you've survived 5 years, you're in remission, and yeah, your likelihood of surviving past that is pretty good. Leukopenia. Leukopenia, just like thrombocytopenia you learned about in lab, is too little platelets. Leukopenia is too little white blood cells. This can be due to drugs like glucocorticoids. We talked about cortisol and how it suppresses your immune system. So having injections of glucocorticoids could cause you to have leukopenia or too few white blood cells. Cancer therapy can cause too few white blood cells, because cancer therapy, like chemotherapy, is going to attack the entire body, so your white blood cells as well. So those will lower in number. If you have a viral infection, that can also cause you to have leukopenia. Even though your lymphocytes will go up, usually your other white blood cells will go down. And then also infectious mononucleosis. This is a viral infection of lymphocytes specifically, and total white blood cell count usually will increase. What's a little bit funny about mononucleosis is that it was named wrong. Mononucleosis was named because they thought it was an infection of the monocytes. And the reason why I thought it was an infection of the monocytes is because the cells were so large. And actually what it was a lymphocyte that's been infected that made them look so large. So lymphocytes become infected, they enlarge, and they end up looking like a monocyte. So it was called infectious mononucleosis because they thought those were monocytes when really they were just infected lymphocytes. But they never changed the name to anything that refers to lymphocytes. They kept it as it is. It's still mononucleosis. even though it does not involve monocytes. Okay, so questions about leukocyte disorders. Okay, and then remember that the normal white blood cell count should be 5,000 to 11,000 white blood cells per microliter. Okay, so changes in the number of circulating white blood cell counts could indicate an infection, could indicate poisoning. Poisoning will increase your white blood cell count, leukemia, chemotherapy, parasites, allergic reactions, a whole list of things. And then I gave you the mnemonic device in lab about the abundance of white blood cells. Neutrophils are going to be the most abundant at 50 to 70%. I won't test you on the exact percentages, but you should know which is the most abundant to which is the least abundant. Okay, but these are going to increase when you have a bacterial infection. Lymphocytes are the next most abundant. They're going to increase when you have a viral infection. Monocytes are going to increase whether you have a viral or fungal infection. Remember, they're pretty nonspecific. Eosinophils are going to increase when you have a parasite or an allergic response. And then basophils are going to increase when you have an allergic response and if you have hypothyroidism, although that connection is a little bit less known. And so the mnemonic device that I have is never let monkeys eat bananas, and that goes from most abundant to least abundant. Okay, we find more neutrophils than we do lymphocytes, more lymphocytes than we do monocytes, more monocytes than we do eosinophils, and then the basophils are the most rare, which is why we don't test you on basophils when it comes to microscopy, because they are really difficult to find and really difficult to identify. And I'll give you a second to write that down. Yeah.
Professor, how do the basophils affect hypothyroidism?
I think that connection's a little bit less known, but there is a correlation between an underactive thyroid gland and the number of basophils. Okay, who still needs this slide up? Okay. So platelets are cell fragments that help stop bleeding. And remind me again, what's the name for scientific name for platelets? Thrombocyte. And so just like the other cell development lines, we're going to start off with that hematopoietic stem cell because that can become any one of our blood cells. You don't need to know the stages. Just know that platelets derive from a megakaryocyte. They're literally just pieces of the megakaryocyte that make the platelets. And so our platelets are disc-shaped. They are 2 to 4 micron cell fragments, so very, very small, especially compared to the other blood cells that we have. Our normal platelet count is 150,000 to 400,000 per microliter of blood. They have a very, very short lifespan. They only live for about 5 to 9 days in the bloodstream because their job, it really is just to create that clot, and then we're done with them. They are formed in the bone marrow. They are only circulated in the blood for a few days, and the aged ones are removed by macrophages in the liver and spleen to be recycled. And if the bone marrow were to ever stop producing blood, it's platelets that actually go first. They stop first. We're going to run out of platelets before anything else. So questions about platelets? Okay. So hemostasis is the stoppage of bleeding. And so these are the steps of hemostasis. We kind of previewed it a little bit with the endocrine system, but we're going to talk about it in more detail, and you should know the steps here. The first step is vascular spasm. So what happens here, because your blood vessels, and we'll talk about this more in the next, no, not in the next chapter, that's heart, but the chapter after that, which is blood vessels. Your blood vessels have different layers of different tissues. So the very inside is going to be epithelial. We have some smooth muscle. We have some connective as well. And so the epithelial cells in one layer they're going to release a chemical signal that targets the smooth muscle. And what kind of signaling would that be if we have epithelial cells targeting smooth muscle cells that are right next to it? What is it? Not new. Paracrine. Okay, so we have an epithelial cell releasing a chemical that targets a neighboring cell. They're right next to each other. So epithelial cells will release a paracrine that targets these smooth muscle cells that are right next to it. And so what that's going to do, the epithelial cells release that chemical, it targets the smooth muscle cells, and then the smooth muscle cells are going to contract in order to constrict the blood vessel. And what that vascular spasming is going to do, it's going to decrease blood loss for about 20 to 30 minutes to give the platelets time to form a clot so that we don't lose as much blood. So that's the first step, called vascular spasm. And so next is the platelet plug formation. So injury to lining of vessels exposes collagen fibers, and the platelets are going to stick to it. So it's kind of very similar to those cell adhesion molecules we talked about with the inflammatory response. This is a little bit different. What's going to happen is the injury is going to cause collagen fibers to stick up into the blood vessel, and that tells the platelets where to stop. They're going to stick there in order to try to form a clot or a mesh. And so once the platelets stick, though, they're also going to release chemicals that's going to attract even more platelets. Once those platelets stick, they're going to send out chemicals that's going to cause even more platelets to come and stick. And that's going to keep going and going and going until the clot is fully formed. Okay, and what kind of feedback mechanism does that represent? It's going to be positive, because you're going to increase the amount of platelets, and then increase the amount of chemicals, and then increase the amount of platelets again, which increases the amount of chemicals, and then so on and so forth until the clot is formed. That's going to be a positive feedback. Okay, so that's the platelet plug formation. And then coagulation is where fibrin, which is the active form of what other chemical? Fibrinogen. So fibrinogen is when it's inactive, but when it's time to form a clot, it gets converted to the active form, which is fibrin. The fibrin is going to form a mesh that then traps red blood cells and platelets together, forming that clot, allowing for the healing process to occur. And the fibrin kind of acts like a molecular glue, holding all those red blood cells, holding all those platelets together. Okay, so questions about hemostasis. Anybody still need this slide up? Okay. All right, so next is the blood clotting cascade. One thing that's really funky about the blood clotting cascade is that it's numbered, but it's not numbered in order. It was numbered in the order that the clotting factors were discovered, not in the order that they work. So if you look at it, it goes from clotting factor 12 to 12A, then to 11, then to 9, then to 8, then back to 9, and it really does not go in any kind of order. So you want to make sure that you get this down really well, because you are going to have to memorize this entire clotting cascade. Just kidding, no you don't. Once you get to nursing school, you may have to memorize the clotting cascade, but you don't have to for this class. Okay? I had to wake you guys up a little bit.
Yeah.
So all you have to know about the clotting cascade are the key players. So platelets are going to be forming these clots. Fibrinogen, obviously, when it gets converted to fibrin. Vitamin K is really important in the clotting process. Vitamin K specifically is required to produce the clotting factors. So remember we talked about jaundice before and how newborns have a lot of capillary damage and red blood cell turnover. And so one thing, I don't know if you've remembered this, if you had kids before, but infants usually get a vitamin K injection in their foot. Okay? That allows them to produce more clotting factors to be able to handle that red blood cell turnover, that capillary damage. So infants, and then children before surgery may need vitamin K injections. Because children just may not have enough vitamin K sequestered to take on the trauma and damage that may come from the surgery, so they can get an injection of vitamin K to help them produce more of those clotting factors to help with the healing. Calcium is highly involved in the clotting cascade as well. We use calcium for a lot of different things. Not only this, it's also a second messenger, also involved in muscle contraction. So calcium is used in a lot of different things. And then obviously the clotting factors themselves. So you just need to know the key players of the of clot formation. So questions about that? Okay. And this is just an image showing you that is a fibrin mesh. So that's those fibrin protein strands there. And it's holding all these red blood cells together, as well as platelets forming that mesh that will form the clot and eventually a scab. Okay, the last thing, or not the last thing, but the next thing we're going to talk about is fibrinolysis. Fibrinolysis is, so after a clot forms, it eventually needs to be broken down. So fibrinolysis is the breakdown of a clot after it's done its healing job. So epithelial cells that line the blood vessel are going to release a chemical called TPA. And in your lecture notes, it spells it out. You have to spell it out on an exam. It stands for tissue plasminogen activator. Okay, so TPA stands for tissue plasminogen activator. And it's a clot buster. So it's a chemical that helps to break down that clot when we're done with it. And we can give synthetic TPA to patients if a clot is expected. So if they've experienced a stroke or a heart attack, or you think they're going to, you can administer synthetic TPA to help break down the clot that's keeping oxygen from reaching the heart or the brain. One thing also is during this process of fibrinolysis, of breaking down a clot, a protein called a D-dimer is released during this process. So if you suspect that a patient is forming clots, you can do a blood test and see what their D-dimer levels look like. If they're elevated, meaning clot breakdown is happening a lot, then you can confirm that that's what's occurring. So a positive D-dimer test tells you that clots are being broken down, so clots have formed. But that's not a diagnosis, so don't put that down yet. This is a process, not a diagnosis. So questions about fibrinolysis?
Can you repeat
TPA is a chemical that helps break down the clot. Oh, tissue plasminogen activator. So tissue plasminogen activator. But it is listed in your notes, yeah? Yeah, okay. Okay, everyone good here? All right, so sometimes those clots can get stuck to the wall of the vessel. So when a blood clot is attached to a vessel wall, we call it a thrombus. Now, it's not always going to be a blood clot. Sometimes it could be plaque, atherosclerotic plaque that has formed in your vessels can form a thrombus. And then an embolus is when part of that clot or part of the plaque actually breaks off from the thrombus and is allowed to free float in circulation. So a thrombus is when it's attached to the wall, and then when a piece breaks free and circulates, that's when it's called an embolus. And what's dangerous about an embolus is that that embolus can get stuck in a smaller vessel like a capillary and obstruct blood flow. And when it does that, it's considered an embolism. So an embolism, and I believe this is in your notes as well, is an obstruction of a blood vessel via an embolus. So when you have an embolism and there's a blockage of blood flow, the tissue that's fed nutrients by that blood is going to die or can die by hypoxia. If it's no longer getting the oxygen it needs because an embolus is now stuck, causing an embolism, then that tissue that needs that blood may die from hypoxia. The really high-risk organs for embolisms are going to be your heart. Okay, you do not want to have blood flow obstructed at the heart, because then you would cause your heart tissue to die, which is going to cause a heart attack. At the lungs, you do not want an embolism to occur, because that's going to stop airflow coming in and out of the body. And then the brain also. Your brain needs oxygen. It's not going to live for longer than a couple minutes without oxygen. And so if you have a blockage there, that's really, really dangerous. And again, because you cannot live for very long if you're not getting your brain oxygenated. And again, not only blood clots, not only plaque can travel through vessels this way or travel through vessels this way, causing like the embolus. It also can be in air. You can have air embolus. So that's why when you see a nurse putting in liquid to an IV, they usually have to make sure that there's no air in the syringe, because again, you do not want an air embolus either, because if you get air stuck, that can also obstruct blood flow. Okay. Know that thrombus is singular. Thrombi is plural. An embolus is also singular. And emboli is plural. So questions on the difference between a thrombus and an embolus. Okay. So a disorder we're going to talk about is deep vein thrombosis. So this is when a clot forms in one or more of the deep veins of your body, usually in the legs, because the vessels of the legs, the veins specifically, they are lower pressure veins. And so when you have clots forming and thrombi forming in the veins of the legs, symptoms that you're going to experience, and this is actually a leading cause of death here in the United States. symptoms or signs and symptoms that you're going to see are going to be leg swelling. That would be a sign. You can see leg swelling. Leg pain. That would be more of a symptom. It can cause a change in your skin color at the legs. And the legs may be warm to the touch. This is going to be different from varicose veins. We're going to talk about varicose veins when we get to blood vessels. But risk factors of deep vein thrombosis include your age. If you're greater than 60, you're more likely to develop deep vein thrombosis. If you're bedridden, because if you're laying down for long periods of time, your blood isn't circulating as well as it should. It can pool in the legs, and when your when your blood pools or stays in one place longer than it should, it's more likely to form clots. Which is why when people are bedridden, they may put blood pressure cuffs on their legs or ankles to get blood flow going, or they may be massaged on their legs as well just to get that circulation going so that they're not forming clots and that blood isn't staying stagnant. Also, if you sit for long periods, that's why if you're on an international flight or a really long flight, they suggest you get up and you walk around periodically during the flight so that your blood doesn't pool in your legs, doesn't stay in one spot, get it circulating. Injuries to the legs can make you more likely to develop DVT. Pregnancy. Or obesity. And the reason for that is if you have a large belly, you're creating more downward pressure towards your legs. And it's harder to get that blood to come up against that pressure and circulate. Smoking also. I don't know if you've seen somebody who's smoked for a very long time, but their skin looks really dry and wrinkly and dehydrated. Now that's what you see on the outside. Essentially all their organs on the inside are also going to look that way, all dehydrated, and walls are weak and such, which is why a lot of these cardiovascular diseases are associated with smoking, because it makes these parts of the body weaker, dehydrates them. Some other things, birth control pills or any kind of hormone therapy can make it more likely that you form blood clots. And then some of us are just real lucky and just have genetics that make us more likely to develop DVT as well. So questions about deep vein thrombosis. Okay. Anybody still need these notes up? Okay. So if an embolus is traveling due to deep vein thrombosis in the legs and returns to the right atrium, so the first chamber of the heart, it's really not going to cause any issues when it's going from the legs to the heart, because from the legs to the heart, those vessels actually get bigger and bigger as they approach the heart, so they're not really going to get stuck anywhere on their way to the heart. Where it's going to get stuck is when it goes through the heart, and heart chambers are large as well. It's not going to get stuck there. It's when the blood travels out from the heart to the lungs, where there's very small capillaries where gas exchange occurs. That's when you're going to have a problem. So when you have a embolus stuck in the capillaries at the lungs, that's what we call a pulmonary embolism, which can be fatal, because you're essentially stopping oxygen from being able to come in and oxygenate our blood and our tissues. So questions on DVT or pulmonary embolisms? Okay. So some anticoagulation meds. Heparin is quick. It can be injected. It prevents clots. What we're going to talk about a little bit later today is that we have test tubes for blood samples that are lined with heparin. Because if we were just to take a blood sample and just put it into a test tube that had nothing in it, the blood tends to want to clot outside the body. So we line the tubes with heparin so it thins out the blood so it does not clot. So we can centrifuge it and run testing and do whatever it is we need to do. Warfarin or Coumadin, I don't know how warfarin, but it's another anticoagulation med. It's going to be slower acting. It's going to be acting on the long term. It prevents or reduces coagulation by inhibiting some of those clotting factors that are needed to form clots. Aspirin is another blood thinner. It interferes with platelets, so it prevents that stickiness when clots form. And aspirin is pretty routine to prescribe once you get over about 60 years of age. And then TPA, like we mentioned before, it breaks down existing clots. We have naturally occurring TPA that we create ourselves, and then there's also synthetic TPA that can be prescribed. So signs of bleeding disorders like the thrombocytopenia that you learned about in lab, a sign would be bruising or petechiae that you learned about in lab as well. So petechiae are the spots that you see on the skin, and this is due to everyday capillary damage that isn't healed fast enough. So we experience capillary damage on a daily basis. It's just natural part of living, but you're not aware of it, and it doesn't show up on your skin because you have enough platelets to cover that capillary damage, and the healing happens pretty fast. People who have thrombocytopenia and have too few platelets who are not healing that capillary damage fast enough, it shows up as spots on the surface of the skin. Some other bleeding disorders with thrombocytopenia, again, you learned about that in labs, too few platelets. If you have impaired liver function, the liver is responsible also for making clotting factors and fibrinogen. And so if you have impaired liver function, you're not going to be able to heal capillary damage if you didn't have, as well as if you didn't have impaired liver function. Or if you don't have enough vitamin K. We said vitamin K is needed to make those clotting factors. Hemophilia is a genetic cause for a lack of clotting factors. Hemophilia is a X-linked disorder, meaning that it's more common in males than it is in females. It used to run in a lot of European royal families because they would inbreed and date cousins and such, so they would pass on those same genes. So there would be a lot of royal princes that would have hemophilia, which means that they can easily bleed out. You fall off your horse and then die because you bleed out because you don't have enough clotting factors, okay, from that hemophilia. Now, that was hundreds and hundreds of years ago, but now we can give people the clotting factors that they're missing. So not as big of an issue now. Disseminated intravascular clotting, or DIC. This is widespread systemic clotting, which uses up all the clotting factors, and then it's followed by bleeding. Okay? This can be a complication of pregnancy or toxins from diseases. Also, if you were to get a large infection that led to septicemia, that can also cause DIC. Or if you were to have received a bad blood transfusion, that can also cause DIC. So once DIC occurs, it's really hard to help that person survive because, again, they are forming clots all around the body, using up all their available clotting factors, and then they bleed out because they don't have any clotting factors to take care of the damage. So like I mentioned before, in our blood sample tubes, we do line it with heparin, so an anticoagulant is added to the test tube because blood likes to clot when it's outside the body. We don't want that to occur when we take a blood sample for the most part. So we put heparin inside the tube. And so when anticoagulant is added, no clot is formed, and that fluid at the top of our layers is going to be plasma. That's what it's called when all of the components are there. Now, if no anticoagulant is added, then a clot will form because that's how blood likes to act outside the body. So if no coagulant is added, no anticoagulant is added, a clot forms. And what that means is now that plasma is missing things that it had before. So it's missing clotting factors, it's missing fibrinogen or fibrin because it formed that clot. And so because it's missing parts of that plasma, we now call that plasma serum. Okay? Because again, now it's missing clotting factors, missing vitamin K, missing fibrinogen, and so now we call it something different. Okay? It's called serum. That will be a question on your next exam, so put a star next to it, highlight it. Okay? If there's heparin in the tube, it's still plasma, but if there's no heparin in the tube, then that top layer is going to be called serum. Okay, questions about that? Okay. All right, so sites to obtain blood, we can do a venipuncture. Venipuncture is easiest because it's going to have a lower blood pressure than our arteries. We'll learn about it a little bit later, but the median cubital vein, which is one of the vessels that you have to learn, is the most common site of venipuncture. A finger stick can be taken, so many people who check their blood sugar levels daily will use a finger stick. A heel stick, like we said before, with the vitamin K injections for newborns. I don't know if you've seen this before, but many times when we do a heel stick, I'm not a medical professional, but when medical professionals do a heel stick on an infant, they'll put a warm cloth on the bottom of their foot. And if you remember from the integumentary system, when you're hot, your vessels dilate so that more heat kind of dissipates from your skin. So what we do for infants, I keep saying we, but what professionals do for infants, they put that warm cloth on the foot to dilate the vessel so the vessel is closer to the surface of the skin, so it's easier to take that blood sample. Right? So it just makes it closer to where you need to do that that sample. And then our arterial stick, not every phlebotomist can do an arterial stick. You have to be specially trained to do an arterial stick because that's a much higher pressure vessel, and it's usually used to test levels of our respiratory gases. Oh, that should be 2 S's. Go back. So used to test the levels of respiratory gases, specifically in our oxygenated blood. So questions about the different sites to obtain blood. Okay. And then different blood tests that can be done are going to be a complete blood cell count, which is going to include your red blood cell count in millions per microliter, 5 million for female, 6 million for male. Your white blood cell count, which is in thousands per microliter, so it should be between 5,000 and 11,000 white blood cells per microliter. It'll give a differential, which is going to be the percentage of each one of those blood cell types. And then also to give you your hemoglobin in grams as well as your hematocrit percentage. We can test for clotting factors. This is going to be a time test where they see how fast a clot can form. We can get a platelet count or also a comprehensive metabolic panel or a CMP, which will tell you all of your solutes in your blood. How much glucose do you have? How much of your electrolytes? How much sodium, potassium, calcium, things like that. Hormones. Questions? Okay. I'm going to stop the recording.